There we go. Good afternoon, everyone. Welcome to this demo box session. My name is Katarzyna Kotfis. I am a senior consultant anesthetist and intensivist at the Pomeranian Medical University, University Hospital Number 2 in Szczecin, Poland. And I have the pleasure of having this session with Axel Nierhaus. Could you introduce yourself, Axel?
Yeah, hi everyone. I'm Axel Nierhaus from Hamburg, Germany. I'm a clinician and a senior consultant intensivist at Hamburg University in the north of Germany. I'm happy to share this session with you and with you, Katarzyna. And I think we do it like a duet. So I think Katarzyna will start with some ideas on human error, and I will later step in and tell you something that happened actually in our department. But please be as interactive as possible, because this is a very informal format. So don't be shy to ask something or to say, no, that's rubbish, I think it's different. So please do interact, because otherwise it's just another presentation.
Exactly as Axel said. We'll just start off putting a background into the whole situation. Human errors are part of patient safety, and that is avoidance, prevention, and amelioration of adverse outcomes. And that is a process embedded into healthcare. And the quality of the care that we provide is, or has to be, the iris of it, the patient focus. One of these elements that we're talking about is human factors and human errors, but there are many others that can interfere in the patient process within the hospital. So the hospital risk management is based not only on the interplay of the avoidance of human errors, but also on the avoidance of technical hazards, appropriate leadership within the department and the whole area, procedural, educational purposes, financial and organizational issues that can lead to errors as well. Now, human errors are the primary sources of complications, not just in healthcare, but in any industry with high turnover. Usually that happens as lack of knowledge or skills. Some errors are avoidable, some are not. But individual errors can be minimized with checklists, with appropriate training. And Axel will talk about the blame game, so the perspective where an error occurs and we are not trying to find the solution for the future, but trying to find the person responsible for it. Now, in critical care, the most common, and I hope you agree with that there are different levels to the errors that we encounter, can be communication errors, diagnostic, procedural, decision-making based on the diagnostic process. Sometimes it is just documentation, so we identify the problem correctly, we treat it correctly, but we document it erroneously. Equipment-related factors and medication errors. And here's one of the errors that I would like to share with you. That is a medication error that could have happened. And this is a picture from my department. We had adrenaline and noradrenaline with almost the same name on the box. If they're used, so adrenaline and adrenor seems to be very closely related. The packaging has been changed into proper naming in Polish, adrenaline and noradrenaline, but the space for error was very, very small. Now, if an error in healthcare...
May I interrupt you?
Yep.
Has anybody had similar experience with labeling of drugs in your clinic? Does this ring a bell with similar names and alike-looking packages? What was your experience?
I'm not sure exactly what drug it was, but it was extremely similar. The same color coding with a green line, and you really had to look well into it. And unfortunately, there wasn't much of a background, so I had to put actually a hand to read it properly. And we have a system where we have sort of small, drawers, and all the vials are actually placed into the drawers. So unfortunately, the mistake was from the stacking person, and they put the wrong vials in the wrong drawer. And of course, our WhatsApp departmental WhatsApp group went crazy, everyone flagging the mistake. So thankfully, we realized.
Thank you very much. So there's again another level or other layer, because it was the packing guys who probably did the first step. And what happened? Did you fire them? Because that would be the blame game.
Blame game, exactly. But when coming, go ahead.
They say, this is aniline, isn't it? And you seem to read whatever they say that you're supposed to read. It's just a kind of bias, and then you make a mistake.
That's what we call confirmation bias.
You're absolutely right. And even if we check either the syringe or the vial 3 times, you can still make the same mistakes. And getting back to the medication errors, I don't know, everybody works in a different background. I come from Poland, and I think what we are experiencing right now will be everywhere. There is a shortage of certain drugs, and they are imported from different countries, and many legislation backgrounds do not require translation. So on the package or on the vial, it only says the international name of the drug. And sometimes it is written in different languages. We do get drugs from India. We do get drugs from China. And it is just that you have to closely look for the international name and sometimes recalculate the doses to what you're used to using. So to me, that's a very high area for bias. And this is a way to go for the pharmacy to actually repackage locally all those medications. But there are different ways to avoid the medication errors. And this is just a bow tie diagram showing one way to approach as per organizational safety. If there's an event that has occurred that needs assessment by an interdisciplinary team, and the structure of the bow tie identifies the known hazards that can be avoided, those that are traps, which are anomalies that we could have not foreseen because they are so case relevant and only that case relevant, and there are 2 elements for the recovery from a critical event. One will be the rescue from the harm once it occurs, so what to do immediately, so immediate management, but also the post-crisis management. But the most important element is how to, as a team, avoid in the future the outcome. So what we do if it occurs, if it's a near miss, what is the level of harm? Everything needs to be discussed within the team. And the whole hospital, and what is the learning from it? What is the reflection? So the only real mistake, if we avoid the blame game, is the one that we learn nothing from. And with that, I'll give the floor to Axel.
Any questions or comments so far? Any ideas? Okay. Could I have my presentation, please? It's the other one, and yes. Now, would you please close your eyes, because I have to advance a bit. I have to go through human error. No, not yet. I'll tell you when to close your eyes. It's a very important point, I think, that human error is not human failure. So you really have to appreciate that you are working in a team, and every team member, no matter what the profession is, has the right to make a mistake, of course. So failure is not the word, and errors are many. And now I will skip through a couple of slides, and I'll show you. I don't want to go into all this theoretical stuff. If you want, you can read it with James Reason. I will give you a very interesting example of my clinic. Hang on a minute. Okay, now have a look at this picture closely. It's a riddle. Do you see anything that you find worth a comment?
Are these pictures come from the same hospital?
Yeah, it's the same hospital. It's even the same ICU. Hang on.
The one bed has the oxygen on the left, but the other bed has the oxygen on the right.
Yeah, quite right. It's the same sort of device. However, one has the oxygen knob on the left and the other on the right. And this device is on the same ward, doing essentially the same thing, mixing air and oxygen. So you can imagine what happens. In this patient, we had 2 liters per minute oxygen, 13 liters per minute air. The resulting FiO2 was 0.3, and the resulting PaO2 in the patient was 81 millimeters of mercury. Perfect. That's what we wanted, didn't we? In the other bed, things were different because somebody didn't quite look what he was or she was turning, which knob. It resulted in 11 liters O2, 4 liter air, FiO2 of 0.8, and an oxygen level of 366. So, well, it didn't really hurt the patient, but it could have, couldn't it? So this is an inbuilt device error or technical error. And how would you get rid of that? What would you do? What's the simple solution?
Make every bed space identical.
That's the obvious solution, of course. You throw out maybe this mixer here or that and keep just one type of mixing device for the whole department. Actually, we have 110 ICU beds in my clinic, adult ICU beds. And, well, would be quite a waste of money, wouldn't it? What we instead did, we also wasted a lot of money. What we did, we introduced this device. Where's the pointer here? Is that a pointer? No. This device, it shows you the FiO2 post-mixer. So no matter what you do here, you always see the FiO2 coming out of the device and reaching the patient. It could be, apart from throwing out one type of mixers, could be a solution too. Okay, any questions or comments for that?
Have you had that similar situation with equipment, like inborn or initial failure? Because that's not something that breaks down. This is something that was ill-designed from the very beginning. Someone who was preparing the equipment for us does not understand the way we work. So have you had that problem before, that you entered a space that was completely ill-designed in your unit?
Well, it wasn't ill-designed.
It was just...
This device is quite as good as that one.
But it should all be the same.
The problem is not the manufacturer had the problem. We, buying these things, had the problem. So we should have only bought from one manufacturer and not mixing things up. So that's a latent error or a latent source of error in your maybe in your department. Now look at these attitudes, and I wonder if you know anybody saying or thinking that this never happens here, this never happens to me. We have always been doing this like that. That's a very strong argument, isn't it? There's no time for this now. I'll do it later. I don't believe these values. It's simply impossible. Must be a wrong measurement. Oh, I know, Dr. XY does it differently. I don't know why. I do it my way. All right, I know I should. I leave this out for now, okay? But don't tell anyone. Guidelines. I don't need guidelines. This is for wimps. and complications, not on my watch. I've done this 1,000 times. What could possibly go wrong? And of course, these are thoughtless attitudes, unsafe acts, and hazardous acts if you do it with these attitudes in mind. I'm sure nobody ever has had these ideas in mind, but maybe some of your colleagues had who are not here. So the Swiss cheese model you're probably very much familiar with. James Reason, in the 90s, he published that, wrote a very good book about human error. And I don't have to explain that. I think latent errors in the system that propagate mistakes until, for example, the patient develops AIDS due to improper ventilation technique, due to inadequate training and staffing skills, due to lack of supervision, and due to lack of communication and availability of guidelines. You can insert any catastrophic event here on the left side, but the mechanism will always be the same. So, what Katarzyna said, name, blame, and shame, that's the name and blame game. We wait for something to go wrong. Obviously, a lot of things will go wrong. Then we use the so-called London Protocol. We establish what happened. We attribute actions to actual people who did what when. And we try to establish the root cause. And then, and that's the idea of the whole process, we make changes to the system so the accident does not recur. That's the normal way, protocolized, how we handle errors and mistakes. You're all familiar with that. And of course, it's not anonymous. And of course, in some areas or in some hospitals or even in some mindsets, it can degenerate into the name and blame game. There's another concept, the safety 2 concept. And this is completely different, fundamentally different from safety 1. We look differently. We look at good and acceptable outcomes, and we look from behind, what went well and why. And this is a completely different approach, I think. So we have to understand in future, I think, why things go right in complex systems and how we can enhance our system to mitigate risk of failure in the first place, and then use safety 1 to analyze mistakes. So safety 2 is something you have to keep in your mind. The near-miss events are very important. If you have a system like the critical incident reporting system you may probably have in your institution, then this is the chance to get the most of any kind of mistake. Analyze the near-miss event and then look by the methodology of safety 1, you find the root cause and you may eliminate it. However, as I said, more advanced, I think, and much more positive is to add safety 2 aspects, meaning that on the right-hand side here, as a tool to understand what went right, why exactly the patient got out of the ICU in the end, and you are based on what can be learned by the event, and you analyze what other protective factors have been during the stay of the patient at your department. I think that's much more important than only to look at mistakes. And so you can focus on preventing negative outcomes in the future, I think. That's a very important approach. And it's rather novel, actually. Understand work as done, not work as intended. We all know what's intended by the SOPs, by the guidelines, etc. But as close as you would look at a mistake in the safety 1 approach, look closely at the good outcome and understand why it went well. Study the actual practices, adaptations, and adjustments made by you and your co-workers during their daily work. It's very important not just to work and not analyze what you are doing, and only analyze things when things go wrong. And focus on successes. Learn from what goes right in the system, recognize that understanding successful outcomes can provide valuable insights into how to strengthen system resilience, and not only by strengthen system resilience by analyzing the mistakes. Adaptability is the difference between work as intended and work as done with a good outcome. So, in the end, it's all about promote a learning culture in your hospital and to collaborate and communicate. And to close, I have some ideas how you could probably approach your and your colleagues' work, everyday's work, differently. Ask yourself or ask your colleague, tell me a story about an experience at work where you felt you performed well or made a difference. What happened? What exactly happened? What were you particularly proud of, and what was the outcome? Tell me about 3 of your strengths. This is also something positively enhancing people's performance. How do these strengths positively support your work? And what do you value about your work? What's the most satisfying thing about your job? And can you give me an actual example of when you improved safety directly for a patient or within your organization? And tell me 3 more small wishes that you have for your team and or your own work. I think this sounds very, like a church sermon, but it isn't. You can work like that on a daily basis, and in parallel, you're still using Safety 1, analyzing mistakes, doing the London Protocol, but also looking at things from the other way around. What went well with this patient, the septic shock, whom I saved and who went home afterwards? You would say, well, that's fine. That's why we are there, to make people healthy again. But it's worth to look very, without emotions, very technically at a good outcome. Why exactly was a good outcome? And I think organizations can learn a lot, looking not only at bad, but also at the good outcomes. Thank you very much.
Do you have any questions or ideas that you would like to discuss? Because this is an interactive session. So if you have identified problems in your department that we could learn from you, that would be great.
Just one thing, Marit de Vos, which is one of the founders of Safety 2, always said, if you want your marriage to succeed, you don't only ask the ones who are divorced, you also ask the ones whose marriage succeeds. I think it's quite a good remark.
So you're familiar with the Safety 2 approach. Where are you from?
Holland, OVG.
And do you have a system that works?
Can you take the mic and tell us how your hospital works with safety
we still find it quite difficult. You have this learning teams. With some of the hospitals we are affiliated with use, but it's not quite a good way to do a root cause analysis, because if something went wrong, a learning team doesn't always help, because you try to look for the steps which are followed before something happens, and doesn't even need to have gone something wrong. But we also have learning from excellence in our ICU, which is like a mailbox where you can put in something that went really well that day, just to give a compliment, but also to see why did things go well. And we hope to get a different mindset. But people always feel like if everything goes well, it's normal. It's not something special, not something you have to think about. They only want to think about things that go wrong. So you have to... The change of mindset is quite difficult to get.
Do you think it's a good way to go, to change the mindset to positivity?
I hope so, yeah. I've got the feeling with the divorce, what I told before, but we are still not there. So I have to see where we will end in the time.
Does anybody else have got that experience in your units? Do you do the positivity enhancement? Not really. We don't. We have to change. You do. Can you take the mic and tell us a bit? Go ahead.
in my experience, it's already difficult to have everybody on site for morbidity and mortality discussion.
Analysis.
So it would be even more difficult to have presence of a survival and rehabilitation session. Nobody would come to discuss how it went well.
You really think so? But look at the cards that we sometimes get from the patients. Don't they enlighten us? And this is a positive feedback that we get when we get a card or an information that patient is home, doing well, and getting back to work. So
Yes.
that's the positive, the survival curve.
It would be a great thing for everybody to interact on things that went well, but since there is already less interest to come to a session to discuss what went wrong, I think the feedback given on things that went well, it's the presence to discuss with people what goes well and find time in a busy schedule to have the meeting. It's difficult to let people come to discuss on what goes well because, as you said, everybody expects that it went well, and we don't congratulate on things that go well, and we just say it's normal that it goes well.
Well, that means we need to change the mindset and organizational practices and culture, I'd say.
My name is Sabrina. I'm from Brazil, and besides an intensivist, I'm also a palliative care physician. So we do a lot of positive feedback, but we do not have this special instances to do. We don't do a meeting. We don't do a Google Meet. Instead, we give those positive feedbacks, for example, on the rounds. So we just discuss, this patient died yesterday, but Fernando addressed the family so well that they were very thankful. And so we don't use it like a focal moment, but we try to do it. And in the first day that we have interns every month, we ask them, when someone did something better than the last day, just say it. Oh, you did this so well, because it just kind of creates a respectful and recognized environment.
That's a very good first step, I think, because you have to carry on doing this, but very, almost without emotion, very technically. On the one side, you say, this went wrong, and there was such and such mistake, and we analyze this. And you do exactly the same thing, analyzing technocratically the good outcomes. And then you will see that it's not only expected and nice, but it's also a chain of events that leads to a good outcome. And the point is to analyze these events and then to reinforce your organization or your ward. So I think there can be done a lot, not just saying, that went well, next. What exactly went well? And then you can, go from there and change maybe the next trajectory of the next patient. So I think we have come to an end. Thank you all for coming. Thank you for
very much.
taking part. And have a nice day.